All right, so with that, I'm going to begin the first part of this session, talking about risk assessment of patients with CLL in the era of novel therapeutics. And I think that this really is what I will hopefully be able to show you during this talk, really the most important frontier that we have to address in really helping our patients' longevity. So as we've all seen from many times with this actual slide, the survival of patients really has improved over the decades, and you can see the change here from the pre-1980s all the way up to 2000, and these are patients actually specifically at MD Anderson. But one of the things that's important is, while it looks like on those curves we are doing better, in actuality, stage for stage, the improvement in survival has really not changed. What's really happened is sort of a lead time bias and an increase in the diagnosis of patients in Binet stage A and not the later stages from earlier cohorts. So you can see here in the 70s, only 26% of patients were diagnosed in Binet stage A, whereas in the 90s it actually was up to 72%. So we need to do better, and the question is, how can we do this? So these are once again data from MD Anderson, the courtesy of Dr. Keating, looking at what they call the FCR 300. And you can see here the progression-free survival curve and the overall survival curve for these patients. And one could look at these curves and say, we're doing pretty good. You know, here we are out well beyond 10 years, and it looks like we have a plateau of about 40%. We're maybe curing 40% of our CLL patients, and that's a very strong statement. And and even with the cure rate of only 40%, we still have almost 60% of our patients alive and well at that point in time. But when you look at these curves a little bit more in depth, what you can see is that the vast majority of people on the good part of this curve are the people who are IGVH mutated. And so perhaps that we're really curing those patients that we would have expected to have done well anyway. And the ultimate question is also, is 10 years sufficient to call it a cure? But what I think is also the most important question to keep in mind is we're providing FCR chemotherapy, which is associated with an 8% risk of myelodysplastic syndrome and secondary AML, as well as a marked increase in secondary malignancies to patients who we're talking about living 10 years. And all of a sudden, when we're talking about having our patients live 10 years, we need to start thinking about those secondary effects. Previously, when our patients weren't living that long, it really was a moot point. So why risk assessment? All right, CLL is a disease of tremendous variability in its clinical course. 70% of patients will die as a result of CLL or complications of CLL. Currently approved therapies are associated with significant toxicities, and tailoring those treatments to limit the toxicity to those who really need it really would be an important part of pushing that survival curve further out. So here's a very partial list of prognostic markers, and I'd like to highlight, what we have clinically are mostly what we would consider to be the traditional prognostic markers, and these I also like to call sort of the organism-based ones. So these are the ones that really pertain to the entire patient. And some of these are pre-treatment prognostic markers, and some of these are post-treatment prognostic markers. And keep in mind that the post-treatment prognostic markers really aren't helpful in guiding therapy most of the time. And then we have all of our new ones, including the most genetic ones and more cell-based ones, including serum BCMA. And then here, looking specifically down at the ones that are most clinically used, we have our traditional and our novel prognostic markers. And using these prognostic markers, we can really generate very nice curves separating patients based upon immunoglobulin G mutational status, interphase FISH. And remember, we have our 4 groups, 17p, 11q, 13q, and trisomy 12, or none of the above. And I always like to emphasize the fact that the normal is really not normal, but none of the above, and that you only see what you're fishing for. But I'd also like to emphasize that in the original paper by Donner, all the patients who had multiple karyotypic abnormalities, or interphase FISH abnormalities specifically, were not included in their group. So if someone has a 13q deletion and an 11q deletion, they weren't included in that 13q group. And it's important when we start talking about complex karyotypes and sort of the ability of these patients to actually have ongoing genetic damage and changes probably is a hallmark of something that we need to think about in terms of which CLL patients are at risk of progression, transformation, and death. So in the era of B-cell receptor antagonists, we have some phase 2 data that Dr. Coutray is going to go into more in depth in a couple of moments. But you can see here, this is the treatment-naive curve for patients who received Ibrutinib when they met classic criteria for requiring treatment and were over the age of 65. This curve actually had only one deletion 17p patient that transformed at 8 months. So in essence, what I'd like to really emphasize about this curve is if you're not 17p, we can do really, really well for you. And the question is, so this 17p really represents sort of the first thing that can go wrong with our patients, and one that's really probably the most significant to control. And when you look at the second curve here, which are the relapsed and refractory patients treated on the same phase 2 study, you can once again see that the PFS falls, the median PFS falls. The median PFS is not reached, I apologize, but the curve certainly separates, and we actually have about a 25% failure rate at 30 months. So clearly there are patients who are falling out of off these curves, and those are the ones where I think we really need to direct our questions to. Now, a lot of people are discontinuing therapy because they have adverse events, and a lot of people are not a lot, excuse me. Some people are discontinuing due to disease progression. So it's important to take a look at these groups individually. So at 12 months, you can see that the cumulative incidence of discontinuing therapy for CLL progression is 0.3, whereas for Richter's transformations, it's 4.5%, and then other events, 13.5%. But when you look at 18 months, you can see that the number of CLL progressors has increased, and the number of our Richter's transformations have also increased, with just a slight increase in people having adverse events. So at least with regard to Ibrutinib, you see that the drug tolerability issues are apparent very early on, but we start to see a hint of CLL progression later on. What I'd like to also point out, and the data here is a little bit premature, but it's perhaps the Richter's transformation will be an early event, and when patients actually remain on and do well, that at that point in time they'll continue to do well. So looking at a recent publication from the OSU group in the Journal of American Medical Association Oncology, out of 308 patients, 31 or 10% discontinued Ibrutinib due to disease progression. 42% of these patients were CLL patients who had CLL, responded, and then progressed with CLL, whereas 58% of these patients, or 18 patients overall, were CLL patients who responded and then progressed by having a Richter's. And I think that this really is an important thing to identify when we start talking about ways to predict who's going to fail Ibrutinib as the sort of the group that we really need to address. So when looking at the CLL patients who responded and then progressed and still had CLL, 11 out of the 13 patients had the mutations that have been shown to affect Ibrutinib's ability to impact upon CLL cell survival. So the BTK mutation most commonly is going to be the CIS41S, where Ibrutinib is unable to covalently bind to BTK, and you end up with a reversible inhibitor that's less effective. Or PLC gamma, which gets upregulated or it gets activated and in essence becomes a bypass loop around BTK inhibition. In the 18 patients who actually developed Richter's, only 2 out of the 18 had these mutations, and some of them actually had the mutations pre-existing. So it really looks like our B-cell receptor antagonists aren't really able to control Richter cell proliferation. So in essence, the top part here is a failure of our therapy. Down here, it's actually not necessarily a failure of our therapy, but our need to have a therapy directed towards a different entity. When looking at variables that are associated with the risk of Richter's, really now trying to focus on, we have CLL patients progress, we can identify in 11 out of 13 a mutation that might help us identify those patients. But now we have the patients who develop Richter's. And when we looked at the patients who develop Richter's, we have 6 findings that on univariate analysis have really shown to be significant. And what I'd really like to highlight is the complex karyotype, which really is the highest risk, and then the BCL6, which is the second highest. What I'd really like to also emphasize is the 17p, which I think really plays a factor in allowing this genomic instability that allows a lot of these mutations to occur. And then when we looked at the original 246 patients treated with Ibrutinib, and this just shows data that was already presented earlier that's also just sort of reminiscent of the OSU group's data. Here we have, out of 150 patients who had been on Ibrutinib more than 12 months, 20 who progressed and 13 who were Richter's. But when you look at these patients here, and this speaks to really the importance of complex karyotyping and predicting who's going to run into trouble, you could see that really all these patients really did have evidence of genomic instability. So I really think that's going to be the first area that we really need to focus on identifying who are those patients that are going to likely do poorly. So the question becomes, is this genomic instability really part of CLL, or is it really just something that arises? And these data here actually are showing the frequency of coding mutations in CLL. And CLL, relatively speaking, and it didn't show up, oh, there it goes. CLL is actually relatively low in terms of the number of mutations associated per exome. So the mean number of mutations per exome is only 21.5, and the paucity of these mutations might be indicative of the importance of either non-coding mutations that we have yet to be able to recognize or epigenetic phenomenon that can drive the CLL clone, or two, and my belief, is that CLL really isn't genetically driven, but is more driven by aberrant B-cell receptor stimulation, either from appropriate signals in the environment or from an abnormal signal in the environment, but really that the B-cell receptor is just being overstimulated and doing what it's supposed to be doing. And one of the things I think that supports this is the genomic or the genetic heterogeneity that we see in CLL. And of course, down here, very few abnormalities are seen in greater than 10% of patients. And when you look at the full range, I mean, this really is sort of a tremendous number of different genetic lesions that can all give rise to CLL. And it really sort of emphasized that this is a disease that's really of the cell and the microenvironment, and that, a lot of different things could then lead to its development. And part of this is the fact that even when we start talking about fludarabine resistance, all right, sort of the worst case scenario in the day of chemotherapy, TP53 disruption, and this is either going to be mutation or deletion 17p, we only see that in 40% of patients who are fludarabine refractory. And if we were going to quickly look at some other recurrent mutations that are associated with fludarabine refractoriness, you can see here quite a few. And these numbers, of course, are different because here they were looking primarily at mutation and not 17p deletion. But you can see Notch1 playing a significant role, SF3B1, FAT1, and then we have a group down here at 3.4%. So there's a lot of other genes that are now becoming apparent. And in essence, these new genes will give us an idea as to who are those patients that we need to be careful about. Who are those patients that are going to likely run into problems with FCR chemotherapy? So the areas I think we need to prognosticate going forward are going to be basically refractoriness to chemotherapy, avoiding exposing those patients who aren't going to benefit to the toxicities associated with the chemotherapy, trying to predict who are those patients that are going to have good responses to TKIs and also durable responses to TKIs, because the way to think about these is that you can also talk about what to do when someone gets into a remission. Which patients do you want to consolidate, or which ones are the patients who are going to be part of that curve that just never falls? And then, of course, the risk of transformation, which will hopefully have some information on how to intervene and sort of change the outcome of that. So overall, and this is taking a step back, and I'm going to actually start focusing on 3 genetic lesions in particular that I think we'll all be hearing a lot about. You could see the prevalence of abnormalities in CLL patients at diagnosis. And of course, the copy number alterations due to the abnormalities of deletion 13q, 11q, and trisomy 12 and 17p are the most common. But what I'd like to emphasize and what I'm going to talk about here is Notch1, SF3B1, and BRC3, which all have some very interesting characteristics that will become relevant to our clinical practices. So one of the first things that I find very interesting is sort of the association of a lot of these mutations with one another. And what you can see here, and I don't know if this projects in the back, but TP53 and Notch1 are almost mutually exclusive. And it's really sort of suggesting that you need one or the other. And the same is actually true for BRC3. And I actually can't even see it from up here, but I believe that's BRC3 right there. And so clearly there's a, both of these can give rise to fludarabine resistance, as I'll show you in a sec, and both of them are mutually exclusive. So there's sort of an idea that if we can identify, and that will increase the number of genetic lesions predicting for fludarabine refractoriness from the 40% for TP53, and eventually, hopefully, we'll get to 100% so we can know exactly what's going to happen ahead of time. So looking at Notch1, Notch1 is a ligand-activated transmembrane protein that plays an important role in cell differentiation, proliferation, and survival. When activated, there's a proteolytic cleavage undergoing on the intracellular portion of the receptor that allows the intracellular portion to translocate to the nucleus and initiate genes transcription, most significantly MYC. And so it plays a role in activating MYC under normal conditions. Now, Notch1 mutations are predominantly going to be premature stop codons, resulting in a Notch1 protein lacking the C-terminal portion. And instead of this missing C-terminal portion leading to an inability to actually transactivate or go to the nucleus, what it does is it actually removes the PES domain, which is really responsible for the degradation of Notch. So in essence, these mutations lead to sort of an increased stability of Notch and an overexuberant activity of it. And this increase in Notch activity is associated with advanced stage of disease at diagnosis, shorter overall survival, adverse prognostic markers, trisomy 12, which is interesting for other reasons I won't go into, but when you think about trisomy 12 and the fact that most trisomy 12 cases are associated with an increase in CD20 expression, Richter's transformations, and decreased progression-free survival and overall survival. And here you can see the prevalence of Notch1 mutations at diagnosis being 18 out of 173 cases, or almost 12%. And then you can see the marked increase there with CLL that's refractory to fludarabine-based chemotherapy and Richter syndromes. And you can see there also that the absence of Notch mutations in de novo DLBCL really suggests that this is something part of the CLL pathophysiology. And looking at treatment-free survival by mutational status of Notch, you can see here that the cumulative probability of treatment-free survival on the left is certainly markedly reduced in the Notch1 mutated patients, and overall survival is markedly reduced as well. And here just shows what I've already mentioned, which Notch1 mutations are associated with adverse prognostic markers. So the second gene I'd like to talk about is SF3B1, which is splice factor 3b subunit 1, and it's a complex that sort of forms part of the splicesome. and it's responsible for mRNA processing. Now, there have been 14 mutations identified, all localized within a C-terminal portion that really sort of interferes with the function of SF3B1. And SF3B1 mutations have been associated with unmutated immunoglobulin gene status, short time to treatment, shorter overall survival, fludarabine refractory disease, and not having an impact on the risk of transformation to Richter's. And here you can see just sort of the mechanism of SF3B1 forming the spliceosome responsible for RNA processing. What's interesting is, we see SF3B1 mutations across all malignancies. And in essence, it's a druggable target, and we have a couple of clinical trials that will be starting up in the near future looking at inhibition of SF3B1 and showing that in the patients who already have a mutated SF3B1, lowering in those malignant cells, lowering the activity of SF3B1 just a little bit could actually cross a threshold that can differentiate a malignant cell from a normal cell. So if the malignant cells are at 30% activity levels, and this is a heterozygous, so it's not a dominant allele, and the normal cells are at 100%, knocking down by 50% will allow that SF3B1 to, by being knocked down to 15, to cross a threshold and lead to cell apoptosis. So this is going to be hopefully a potential target in the not too distant future. And here you can just see the prevalence and the marked increase in CLL patients at when they become fludarabine refractory and not for Richter syndrome. And here you can see the survival curves for time to treatment-free survival and overall survival. And then the last one I want to talk about is BRC3, which is also known as cellular inhibitor of apoptosis 2. And this actually, I think, is a very, very interesting one that will lead to some important identifications of which patients we really need to intervene on early. It's located on chromosome 11q22, and there's some interesting question as to whether or not ATM as a deletion by itself is really responsible for all the behavior that we see in patients who are 11q deleted, or whether or not whether or not BRC3 is also part of that, that disease's behavior. It negatively regulates the MAP3 kinase 14, which is actually also called the NF-kappa B inducing kinase, and it cooperates with TRAF2 and TRAF3, leading to increased NF-kappa B. Now, there's not one specific mutation, but any mutation that disrupts it will play a role. And this disruption leads to basically fludarabine refractory CLL and a poor prognosis, even in the setting of a P53 wild type. Here you can see the prevalence of BRC3 disruption in CLL really being a markedly increased in fludarabine refractory CLL and only present in a small number of patients at diagnosis, and the absence, of course, in fludarabine sensitive CLL and in Richter syndrome. Here you can see the overall survival by patients by BRC3 mutational status, and they really do just as poorly as P53 mutations. So the analogy between these two is actually quite remarkable. And this just shows the idea that it's really right next to ATM, and it'd be interesting to really see whether or not BRC3 is really responsible for a lot of the poor prognosis that's seen with 11q deletions. And this, by the way, is just an interface showing preservation of ATM with loss of BRC3. And I don't know if you can see the two ATM signals and only the one BRC3 signal missing, present. And here you can see the disruption really is localized mostly to this part of the molecule, but it really, all of this results in a non-functional molecule. And in essence, what normally happens is cellular inhibitor of apoptosis 1 and 2, which is really BRC2 and 3, interact with TRAF2 and TRAF3 and NIC1. And in essence, in the role that Occurrence plays in this complex, keeps NIC from activating NF-kappa B and keeps NF-kappa B under control. But in the absence of the cellular inhibitor of apoptosis being able to interact with TRAF1 and TRAF2, you actually get degradation of TRAF3 and marked increased activity of of NF-kappa B inducing kinase. And so in essence, it leads to a marked increase in NF-kappa B activity, something that we see as a hallmark in a lot of resistant cancers. And in looking at the risk for clonal transformations, what I'd like to point out is this is a list looking at a myriad of different things, but here we see the immunoglobulin G mutational status. Here we see the VH4-39, and here we see the Notch1 mutational status. So going back and now looking at individual ones, we can sort of generate our risks. And the question really is a 5-fold risk or a 4.6 risk or a 6.2 increased relative risk going to be sufficient to make us want to interact? And the question, of course, is it's a little bit early and it's going to be hard to know. But when we combine them, and this is Notch by itself in terms of the risk of Richters, but when we combine Notch and VG 4-39, you can see that we're at 100% at 5 years. So all of a sudden now we have a group of patients that we can say there's a 100% chance that you're going to develop a Richter's in 5 years, and that we need to come up with some alternative treatment plan for you. And ultimately, this is what we need going forward. So I'm going to, in summary, just mention that in the era of BCR antagonists and small molecule inhibitors, patients are doing better. We really need to come up with a way to better control transformed disease and predict which patients are going to do better on long-term on TKIs. And when we figure out those patients who aren't going to do well, we need to come up with interventions that will help them. But we also need new data in the BCR antagonist era, and that's going to be the most important thing to help guide us in the future. And what we really want to see is this, which is Ibrutinib versus age-matched controls. And what you can see here is this is the treatment-naive cohort of the patients receiving chlorambucil. And here we have the treatment-naive Ibrutinib patients from the 1102 and 1103 study compared to age-matched controls. And of course, this data is a little bit short, being only median follow-up of about 30 months. But I hope to be back here in another 10 years with the curve all the way out here. Thank you.